Well, hello and welcome to the CSF monthly podcast for September 2020. Well, with the continuation of the current COVID pandemic, this podcast is really aiming to keep you vigilant with the latest update in the field of rheumatology and what are otherwise really very difficult and challenging times, an ominous appearance to the winter in the Northern Hemisphere and the summer in the Southern Hemisphere ahead of us. So let's think a little bit about rheumatology and some of the really fantastic stuff that's going on there. And today I'm going to review two papers which explore the incidence of infection in people treated with baricitinib and the cardiovascular risks associated with tofacitinib use in rheumatoid arthritis and psoriatic arthritis. Now remember, to access detailed summary slides of the papers discussed, please go to CyclingSignalingcom. It's a great resource. If you've been there already, you know that's true, and if you haven't, go and have a look. It really is a terrific place to find slides, updates, brief summaries, and opinion. Well, the first paper is from Kevin Winthrop and his colleagues, and it evaluates the incidence of infection in people with active rheumatoid arthritis treated with baricitinib, which is an oral selective JAK1 and JAK2 inhibitor. Baricitinib demonstrated significant efficacy in phase 3 rheumatoid arthritis trials, and pooled data from these trials, including a long-term extension, suggest and inform the safety profile for baricitinib. The objective of this paper was to further evaluate overall infection risk with baricitinib, with particular focus on serious infection, tuberculosis, herpes zoster, and opportunistic infections. The infections are summarized from an integrated database, 8 phase 3 and phase 2 and 1B clinical trials, and 1 long-term extension. The all-BARI-RA analysis set included patients who received any baricitinib dose. Placebo comparison was based on 6 studies with 4 milligrams and placebo to week 24, including 4 trials also with 2 milligrams. Dose response assessment was based on 4 studies with 2 milligrams and 4 milligrams, including long-term extension data, the 2 to 4 milligram extended set. Note that patients randomized to 2 milligrams and not rescued in the originating study continued on 2 milligrams in the long-term extension, and all others received 4 milligrams. Well, what are the key results? Well, there were increased rates of treatment emergent infections, including herpes zoster. They were observed in patients with rheumatoid arthritis treated with baricitinib, like that observed, I have to say, with other JAK inhibitors. The incidence of serious infection did not increase with baricitinib versus placebo in the 24-week randomized period, but was similar to that reported in other recent targeted synthetic DMARD and biologic DMARD development programs with both short and long-term data. There were 11 cases of tuberculosis reported within the baricitinib program. All occurred with 4 milligrams and in endemic regions. Opportunistic infections, including multidermatomal herpes zoster, were infrequent overall. Well, what do we conclude? Well, in summary, baricitinib treatment was associated with an increased rate of treatment emergent infections in people with rheumatoid arthritis as compared with placebo. The incidence of serious infection was similar to that reported in other recent targeted synthetic DMARD and biologic programs. Herpes zoster risk was elevated with baricitinib treatment, and again, like other JAK inhibitors, was more common amongst Asian patients. Other events of interest, including multidermatomal herpes zoster, were infrequent, and tuberculosis was reported, as we probably would have expected, in appropriate endemic areas. Long-term population-based studies are necessary to better understand this in the real world, and of course we have a large number of registries in different parts of the world that will inform this necessity. Now let me turn to a second paper coming from Philip Mees and colleagues, investigating the incidence of venous and arterial thromboembolic events in tofacitinib for rheumatoid arthritis patients whilst considering previous cardiovascular risk factors. Now, inflammation is a risk for VTA, including DVT and pulmonary embolus and ATE. Labeling of JAK inhibitors includes warnings for thrombosis, and there's an ongoing post-authorization study evaluating risks in people with increased cardiovascular risk factors. Rheumatoid arthritis patients aged more than or equal to 50 and with more than 1 cardiovascular risk factor. And that's evaluating tofacitinib 5 milligrams and 10 milligrams BID as opposed to a TNF inhibitor. The DSMB in February 2019 reported higher incidence of PAE events and all-cause mortality in patients treated with tofacitinib 10 milligrams BID versus TNFI. The current study considers data from this study A39-21-133 and the development program for RA, psoriasis and PSA patients overall. And both clinical and observational and marketing data were considered. The key results then, well, patient demographics, baseline characteristics were balanced across treatment arms. Tofacitinib data were reported for 5 milligrams BID in RA and PSA and 10 milligrams BID in RA and PSA. Now in RA and PSA, the VTE and ATE event incidence rates were similar between tofacitinib and placebo up to 3 months. Tofacitinib, adalimumab and methotrexate in the RA group up to 24 months and the PSA group up to 12 months. And in tofacitinib 5 milligrams and 10 milligrams BID. In both RA and PSA, the incidence rates of VTE and ATA were generally higher in patients with a baseline cardiovascular or VTE risk factor versus patients without, exactly as we would expect. PE IRs with tofacitinib 10 milligrams BID were reportedly higher in study A39-21-133 than overall tofacitinib program for patients with a baseline cardiovascular risk factor. And the most common baseline risk factors in RA patients were CRP greater than 2.87 mg per liter, hypertension, being aged more than or equal to 60, and use of corticosteroids on day 1. Well, again, concluding, it looks like DVT, PE, and ATE IRs are shown to be higher in patients with cardiovascular or VTE risk factors versus those without. IRs were consistent in this study across tofacitinib 5 milligrams and 10 milligram BID programs in the RA and PSA development groups. Observational data is comparable to the tofacitinib development program analyses with consistent IRs in cardiovascular risk factor enriched patients. However, PE IRs with tofacitinib 10 milligrams BID were reportedly higher for patients with a baseline cardiovascular risk factor. This remains a really controversial area. I think we need to just look for more and more data until such times as these data are available to us. We should proceed with caution and, of course, always pay close attention to the label indications that we govern as practitioners. So that's what we've got for you this month. To view other publications, head over to the publications page in CyclingSignalingcom. You'll find slides reviewing the incidence of interstitial lung disease using tofacitinib in RA and the potential prognostic value of anti-CARB-V and anti-MCV autoantibodies in RA treatment. As always, it's a real pleasure to have you joining me for this podcast. I hope you find it useful. I hope it's helpful to you in guiding your clinical practice. And above all else, I hope that you're staying healthy and positive in these very interesting and somewhat challenging COVID times. Looking forward to talking to you again in the next podcast. And meantime, thanks very much indeed.